The phrase microdose GLP-1 sounds safer, cheaper, and easier than standard treatment. Wegovy and Zepbound can work at lower doses for some people, but microdosing is not one validated schedule. A clinician-guided lower dose may be reasonable. The difference is control, not bravery. Splitting pens, guessing syringe units, or stretching injections can create weak treatment, unstable appetite control, or a dosing error. This discussion concerns weekly injections, not the daily Wegovy tablet. Wegovy contains semaglutide, while Zepbound contains Tirzepatide. Both remain in the body for days, so each dose overlaps with medicine left from the prior week. Levels build gradually, so one injection may feel different from the fourth. That overlap explains why a tiny dose can still reduce hunger. It also explains why random changes are hard to judge. A low dose may feel gentle at first, then become stronger over several weeks as medicine remains between injections. The word microdosing hides three different practices. First, some people stay on a starter dose longer or use the lowest approved maintenance dose. Second, others split pens or measure a custom amount. Third, some stretch the interval beyond 1 week. For weekly Wegovy injection, the labeled starting dose is 0.25 milligrams for 4 weeks. The dose then rises in steps. For adults, 1.7 or 2.4 milligrams can be maintenance doses. Some adults may move to 7.2 milligrams after tolerating 2.4 milligrams for at least 4 weeks when more weight loss is needed. Zepbound starts at 2.5 milligrams weekly for 4 weeks. That amount is a starting dose, not a maintenance dose. The approved maintenance choices for weight treatment are 5, 10, or 15 milligrams weekly. Higher doses usually produce greater average weight loss, but also more stomach and bowel effects. The lowest dose is not automatically the healthiest dose. Too much medicine can cause avoidable symptoms. Too little can leave obesity, high blood pressure, sleep apnea, or blood sugar poorly controlled. Safety includes whether the treatment works. A slower increase can be sensible when nausea, constipation, or eating too little appears as the dose rises. The Wegovy label allows a 4-week delay when a dose is not tolerated. Zepbound dosing also considers results and side effects. A planned slower increase is not random microdosing. 2 people can use a lower dose for different reasons. One has steady hunger control, continued weight loss, and manageable symptoms. The other stretches medication because of cost, fear, or online advice. Their dose numbers may look similar, but treatment quality differs. Measuring custom doses creates another risk. A factory-filled pen delivers a set dose. A labeled vial states how much drug is in each milliliter. Counting unapproved clicks, transferring medicine, or converting milligrams to syringe units can cause errors. Custom mixed vials from pharmacies or specialized facilities may use different concentrations. The Food and Drug Administration has received reports of custom mixed semaglutide dosing errors, some requiring hospitalization. Confusion involved milligrams, milliliters, syringe units, and varying concentrations. Many involved people with little experience drawing medicine from a vial. Someone trying to inject less can accidentally inject several times the intended amount. Feeling less nauseated does not prove a microdose is successful. Early scale loss may continue from earlier treatment, reduced food intake, or water changes. A weak dose can look effective for weeks while hunger, cravings, and weight regain quietly return. The opposite problem also occurs. Some people call a dose tiny because the syringe volume looks small. Volume does not reveal drug amount without concentration. A small liquid volume can contain a large dose, especially when the vial is more concentrated. Common dose-related problems include nausea, vomiting, diarrhea, constipation, reflux, and abdominal discomfort. Repeated vomiting or diarrhea can cause dehydration and kidney injury. Severe or persistent abdominal pain, inability to keep fluids down, fainting, or very low blood sugar need prompt medical assessment. Lower dosing does not erase major precautions. These drugs are stopped for weight loss during pregnancy. Before a procedure using anesthesia or medicine that makes you deeply asleep, tell the team because these drugs can slow stomach emptying. Insulin or medicines that force insulin release may need adjustment to prevent dangerously low blood sugar. No universal microdose works for everyone. The strength of appetite reduction and stomach slowing varies widely. A dose that controls one person's hunger may barely affect another person. Personal response matters, but it must be measured against the same treatment goals. Maintenance also differs from starting treatment. After meaningful weight loss, some people may remain stable on a lower approved maintenance dose, others regain hunger or weight after reduction. A lower dose is useful only when the result lasts. The goal is not the smallest injection. It is the lowest dose that produces lasting benefit without unacceptable problems. Judge benefit over time. Judge problems by symptoms, nutrition, cost, dosing accuracy, and whether treatment can continue. Cost is part of that judgment. Multi-use containers may hold medicine after one injection. That medicine belongs to later labeled doses and follows storage and discard rules. Liquid left after all labeled doses is not a safe bonus dose. Start with the treatment goal. Early treatment aims for safe adjustment toward an effective dose. Active weight loss aims for meaningful progress without harmful undereating. Maintenance aims to prevent regain while preserving strength, nutrition, and daily function. A dose can fit one stage but fail another. Then check whether appetite control collapses before the next dose. Strong hunger after 3 or 4 days matters more when portions, cravings, or weight also rise over time. Repeated food thoughts can appear before major regain. One quiet appetite day after injection is not enough. Judge the scale as a trend, not one reading. Waist size, blood pressure, blood sugar when relevant, and sleep apnea symptoms add context. Muscle strength and protein intake matter because rapid loss with weakness is not a clean success. Use 4 checks. First, know the exact weekly dose. Second, use the device exactly as instructed. Third, confirm that benefits last through the week. Fourth, confirm that side effects still allow hydration, nutrition, and normal activity. If all 4 checks pass, a lower approved dose may be enough. If benefits fade, the dose may be too weak to control obesity. If symptoms block eating or drinking, the dose or increase may be excessive. Both failures require adjustment, not guesswork. Change one variable at a time. Keep the weekly day, product, and measurement method consistent while evaluating a dose. Unless safety requires earlier action, several weeks reveal more than a single injection can. Frequent changes make appetite, symptoms, and weight trends impossible to interpret. Extending the interval is especially misleading. These drugs were designed for weekly use, and longer gaps create lower drug levels before the next dose. That can produce a cycle of strong suppression, fading control, and rebound hunger. It is not the same as a stable, lower weekly dose. Show your prescriber or pharmacist the box, vial label, syringe, and instructions before changing anything. State why you want a lower dose. Side effects, maintenance, cost, and fear require different solutions, even when the requested dose sounds identical. A lower dose strategy is smart only when the product, dose, schedule, goals, and follow-up are clear. Calling random dose manipulation microdosing does not make it safer. The best dose is not the maximum or minimum. It is the lowest effective dose that can be repeated accurately. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.